Well, thank you very much. It's interesting I'm going to start by just talking about the fact that in 1999, the Institute of Medicine National Research Council issued a report on the state of HIV prevention in the United States at the request of the Centers for Disease Control. And in that report called No Time to Lose, the Institute of Medicine indicated that whereas the research community was beginning to identify evidence-based interventions for HIV prevention, within the field of HIV prevention practice in the United States, none of these interventions that were showing up in the research literature were being implemented at all in the field. And so we had to think about how would we go forward with beginning to implement evidence-based HIV prevention in this country. I was asked to design and implement that system and that project, which I have been doing for the last 14 years. So I'm going to kind of give you a little bit of a background and some of the lessons learned that we have learned throughout this process. Let me just, as I've been listening today to programs around children, youth, and families, and then thinking about the work we've been doing with HIV, the model that we developed and implemented for dissemination of evidence-based practice, though HIV is a highly politicized disease which impacts highly stigmatized populations. So to some degree, we had, I think there's some things about our dissemination model that may impact what are the interventions, some aspects about the disease, how it's transmitted, and to what populations in terms of considering our dissemination plan. How do I move forward? Is there this guy? Okay. Well, we have the Division of HIV/AIDS Prevention has a research to practice model which moves from epidemiological studies towards research and works its way around. Today's discussion, though, I'm going to really focus on the dissemination aspect of our work in our model. And I want to really just focus on some general lessons learned about dissemination of evidence-based practice that may be of help in the discussions that we're having today. I think the first thing that we had to really think about was how to develop a dissemination infrastructure. What infrastructure should we use? And so we made the decision to use the existing public health delivery system as our mechanism. The CDC has long partnerships with health departments across the country. They in turn fund community-based organizations to provide direct services. They fund around 1,400 community-based organizations to do HIV prevention with dollars that the CDC gives to the various states. So it was this infrastructure that we felt like would be the most logical infrastructure to begin with, and it's the way in which money flows from the CDC. But part of this was that we realized that we needed dissemination agents, or we needed dissemination partners in this process. The first logical partner is, of course, the original efficacy researcher. How do you use the original efficacy researcher and their staff, as part of that dissemination infrastructure? A second part of this is then how can you make sure that that knowledge is moved through organizations that help do training, help build capacity, help do technical assistance, so that you in fact have multiple partners. So we have funded a range of dissemination partners to help us in this process of working with the states, working with community-based organizations. This has a lot of benefits, primarily because different partners have different tentacles reaching into different organizations. And so we were able to take interventions and decide who are the 5 organizations in the country that we would like to move forward with this piece of technology. Or we would take another evidence-based intervention and say, which of the 3 organizations should help us move this piece of technology out into the field, so that we would choose partnerships to think about what is the best marketing and dissemination strategy. Now, we do research synthesis. We look at the evidence of evidence-based interventions, and we publish it on our website of the interventions that the CDC stands behind as having the most evidence of efficacy. And from those interventions, we select the interventions that we would move forward with dissemination. But let me just say a couple of lessons learned. One lesson learned is around the selection of which evidence-based interventions should you move forward with. Now, there's an argument that you should you should look for interventions that have been shown to be effective as compared to efficacious. But at the beginning of the HIV epidemic, there was all efficacy and no effectiveness, So, we had to really think about studies that maybe had just been in one clinical trial to move forward with those interventions. But really, one of the things we found out is that there are interventions that are very complex that were tested under randomized clinical trials that just cannot be implemented under real-world conditions. And so you have to think about what is the feasibility of this intervention in terms of being able to be implemented based on the capacity of the providers in the field. Can they really do this piece of science? Or how much capacity building does it take for organizations to be able to move this piece of science forward? So in our compendium, we've identified 84 evidence-based interventions that have been published in the last 30 years that we feel like meet our criteria for best evidence. And however, with this system, we've had to adjust and make some changes. First, of the 84 evidence-based interventions, we went ahead and packaged 32 of these interventions as packaged interventions. And then from these, we went ahead and moved forward with dissemination of 28 of the 32. Actually, communities frequently will look at an intervention and will tell us whether that's feasible or not. Interventions that have 18 group sessions, those kind of interventions, why should we be surprised when nobody wants to implement that intervention? People say it's just too hard to recruit families to come in 18 times to our agency every Thursday night to get this intervention. And so frequently the customer tells you what interventions are just not appropriate. And when we get that information, we have to let the intervention go. It's just not feasible for the field. Now, I've noticed today there was a little bit of a discussion about evidence-based interventions, packaged interventions, versus evidence-informed or evidence-based practice guidelines or principles. Actually, our approach to this has evolved as we've thought through this a little bit. We have found that for many times, community-based organizations that are founded by advocacy groups, etc., a packaged intervention that gives you how do you recruit the target audience, step by step. Here's the lesson plan. Here's what you say. Here's the PowerPoints that you show. Here's the video that you show. These really concrete steps are very important sometimes for community-based organizations who are grounded in community and may not have the capacity of academic settings, But at the same time, when you're disseminating an intervention to physicians, the practical guidelines or guidelines are a much more effective way. So we don't look at it as should you do packaged interventions or should you do practice guidelines. We look to say, what is the intervention, who will be delivering this intervention, and then let's think about how we adjust it for that delivery mechanism as to whether it's going to be packaged or whether it's going to be principles. Let me go back just a second. Because of the political aspects of HIV, many of our providers were advocacy groups. They were gay rights groups, they were civil rights groups, etc., that began doing our evidence-based interventions and who were the original HIV prevention providers. They made up their own interventions because there was a gap in the research literature. So they had locally developed interventions. So we were not disseminating evidence-based practice into a vacuum. We were disseminating evidence-based practice against locally developed interventions. And that's a very different dynamic when you're thinking about the whole issue around dissemination. So we had to find ways in which to deal with that issue. One of the ways we did was to test reputationally strong programs, so that when we heard about a program that was developed in the community and we saw that they had good process data, they had a good logic model, they were starting to do pre-test, post-test on their clients, they were starting to get changes in the post-test, we said, let's give them an extra $100,000 for 2 years and let's just test their outcomes. Let's see what they're able to do. And from this, we were able to add some interventions into our list of evidence-based interventions that were not developed by academic researchers, but were developed by community practitioners. And so that we could always have this mixture of interventions that come from the academic community, usually NIH funded, all the way to some that were developed from the ground up. From, what's the ratio? Ratio's about 80-20. 80% for academic developed and about 20% for community developed. You hear a lot, if you take this approach, you're going to hear a lot about community, about do our intervention, do our intervention. But when you go in, you frequently find that you have to do a lot of capacity building around making sure they have a logic model, making sure they've got good process measures, making sure that they've got outcome monitoring, making sure that they deliver the intervention the same way each time they deliver it. You know, there's a lot that you have to look at if you're going to look at homegrown or locally developed interventions and include them in the same portfolio as your evidence-based academic developed interventions. So we include the original researcher in the team or in the process of disseminating our work. One of the first things we do is we sit down with the researcher and talk about what is your role going to be? How much of a role do you want to take in the dissemination partnership with the CDC? Some researchers said, I've moved on. You know, CDC can take it and go with it, you know. And then other researchers are micromanagers and they want to work with us on every detail of dissemination of their work. And we try to be flexible around working with the original efficacy researcher about what role they want to play in the dissemination process. But when you get into this, you really get into these two questions about what is the intervention and what really is fidelity, because these two issues can be deceptive. So the first aspect of this is the intervention. The intervention frequently is tested. It's a group of activities that is tested like a black box against some kind of control condition. But yet when you go and you open that black box, you frequently find it's like Pandora's box. There's all kinds of stuff in there. You know, so that there's a technology for marketing, a technology for recruiting, a technology for retaining clients, there's a technology for paying incentives, there's a technology for role play, there's a technology for motivational interviewing, there's a technology for evaluation. There is all kinds of stuff packaged in that, many of which are based on different theories and many of which have different contextual tentacles into the community. And so you really have to kind of think about what is the intervention and figure out what are we really going to be disseminating here? What pieces of this are we going to disseminate and how will they be linked together? And what is the sequential way that community-based organizations can implement these interventions? Now, I think a good dissemination approach requires marketing. Now, the name of our program was Diffusion of Effective Behavioral Interventions, which was abbreviated as DEBI. And so at first people started criticizing it, saying that's such a silly name. And, but you know, I mean, it took off. And so we were hearing Debbie, and it started showing up in the research literature about CDC's Debbies, you know. And so in a way, such a simple name may have been to our benefit in terms of beginning to move the field of HIV prevention towards evidence-based practice. But we found some things that we had to do in the marketing aspect. First of all, we had to market to societal sectors. Health departments are interested in evidence-based interventions in a different way from community-based organizations, and you have to market to them in a different way. We also had to think about incentives and the policy environment so that we began to shape our funding announcements and program announcements so that people could actually get funding to do our evidence-based interventions. We also began to realize that it's better to disseminate families and groups of interventions than single interventions because you want to give consumers choices. By disseminating 28 interventions, people were able to say, oh, this works with this group, or this works better in this, under these circumstances. And thus they had more choices around the evidence-based practice, so that in fact we were able to move forward on various interventions at different speeds and at different rates, depending on what was the consumer choice in the field. And then finally, issue management. We had to, when you're disseminating at a national level, at the federal level, you have to think about protecting your programs. You have to think about what could be the backlash for this intervention going out or that intervention. Most all of our interventions involve the words anal sex. And so, you know, how do you protect programs around terminology like that if someone wants to criticize them? The theme that we saw from day one, and we see it every day, is the tension between adaptation and fidelity. And that is community-based organizations immediately when they learn about an intervention go towards thinking about adaptation. How will they adapt that intervention? The researcher tends to think about fidelity. What did we do in our research? I'm going to tell you about what we did in our research. And adaptation tends to be a secondary thought in many cases, but it's the exact reverse when you're dealing with community. As soon as they start hearing the intervention, they start imagining how they will implement it in their home, in their community, in their agency, with their population, with their staff. And so that adaptation process kicks in, and you have to think about how you're going to use that process. Now, a lesson learned from that. I would suggest never be afraid, if you're disseminating evidence-based practice, never be afraid of adaptation. Adaptation is the dialogue that you, as the agent moving forward with dissemination, have with the adopter. And so they learn the intervention through adaptation. They learn, and you learn more about the intervention through the adaptation process. Adaptation is necessary for ownership, and ownership is necessary for sustainability. You have to have a level of freedom for the programs to be able to adapt the intervention so that they can claim it as their own. And when they claim it as their own, they're more likely to be able to sustain that because they have more enthusiasm about it. So rather than adaptation being a frightening word, adaptation needs to be a stimulus for your dialogue with your providers to begin to move towards fidelity. That's another aspect about fidelity. Fidelity is gained in relationship. I'm convinced of that. It's by dialoguing with the programs about the intervention and its components that you're able to move towards fidelity. Our project officers sometimes freak out and say, this program is only doing half of the program. They're only doing half of this intervention. And I say, well, instead of looking at them as half non-compliant, why don't you look at them as half compliant? You know, they're halfway there. Let's see how we can move them closer, how we can move them further. Just a few final notes. In terms of technology exchange, we really think that we have to go through a co-learning process where we learn from experiences from the field. All of our materials are flexible. We rewrite our materials based on experiences that we learn from the consumer. Implementation of these interventions we see as blending behavioral science with local knowledge. In terms of program evaluation, we still stress formative evaluation. Even if the researchers did formative evaluation, programs have to do formative evaluation if they're going to do evidence-based adaptation of those programs. And then sustainability, be clear as to what is it that you really want sustained. Do you really want the intervention delivered with fidelity? That's one approach. Or do you want concepts that were learned based on evidence-based practice to then be used for improving other programs? In other words, by disseminating evidence-based programs, are you building agency capacity and improving all services that the agencies are delivering? Thank you.
Thank you, Dr. Collins. So our second presenter today is Frances Harding, who serves as the director of SAMHSA's Center for Substance Abuse Prevention, or CSAP, and is recognized as one of the nation's leading experts in the field of alcohol and drug policy. Dr. Harding also serves as a lead for SAMHSA's strategic initiative on prevention of substance abuse and mental illness, which creates communities where individuals, families, schools, faith-based organizations, and workplaces take action to promote emotional health and reduce the likelihood of mental illness, substance abuse, including tobacco and suicide. Director Harding will speak to us about federal partnerships to advance behavioral health and evidence-based practices. Welcome, Dr. Harding.